Well, welcome to the Medicare podcast. And today I have Darin Gordon. Super excited to have you, Darin. And you are a nationally recognized expert in state health insurance plans and founder of Gordon Associates. And today we were talking about the very popular topic of the One Big Beautiful Bill and the changes to Medicaid. And I want to start with, from your long history with Medicaid, can you provide a brief history of Medicaid, why it was created, and who was it intended to cover? What covered less?
Sure, absolutely. Again, happy to be here. Thanks for doing this. Some people may not really fully appreciate, but I think earlier this week, it was the 60th anniversary of Medicaid when it was first put into place. It was created in 1965, originally to fill a critical gap in the broader healthcare system, which was, how do we provide healthcare coverage to low-income individuals who aren't eligible for Medicaid? So initially, it started out focusing on children, pregnant women, seniors needing long-term care, and individuals with disabilities. And obviously, in that context, it's poor, low-income individuals that fit within those categories. Now, over time, it has evolved. There's been critical points along the way where eligibility has changed or been modified. The largest of which was the passage of the ACA, the Affordable Care Act, which added a new category, childless adults below 138% of the poverty line. And when you look at that, kind of where we are from where we started, we are now looking at Medicaid covering over 80 million Americans. So it's quite a journey and quite an evolution.
So I also want to add to that piece of it. Who pays for Medicaid? Like, where does the money come from to pay for those services?
Yeah, it's an interesting model that they developed early on, where in the case of Medicare, where obviously individuals pay into the Medicare system, but the federal government, the Medicare Trust Fund, pays for Medicare. In the case of Medicaid, it is a shared responsibility. I always thought of it as the federal government is my largest investor in my program, and so whenever a state makes an expenditure that is for an eligible individual for a covered service, the federal government will participate at some level. It varies state to state. It also varies by different categories within Medicaid, but let's use like Tennessee as a good example. On average, when Tennessee would spend $1 for services for an individual, the federal government would match that with approximately 65 cents for every dollar spent. There's, again, certain variations. For example, the expansion population, where states have expanded coverage, the federal government will actually participate at 90%. So jointly funded, but administered by states.
And then one last question about just getting a base idea of Medicaid is around what happened during COVID. Did they expand coverage or did it stay the same? What did you see happen during COVID?
COVID was obviously a pretty significant public health emergency, the likes none of us had seen in our lifetimes. And during that period of time, the federal government said, we are going to look at maintaining coverage. A lot of us were trying to figure out what to do next. But one thing that I think everyone could agree on during that period of time was let's not have folks drop out of coverage within Medicaid. So states were asked to pause, I shouldn't say asked, they were required to pause eligibility redeterminations. So they were looking at, how do we stabilize the system broadly, again, given this pretty significant event. Now, what ended up happening in that, obviously, when you're not checking people's eligibility on a regular basis, the rolls swell. And, Medicaid had, I want to say, got up to a point where it was nearly 90 million individuals covered under Medicaid. So you still had people coming on to Medicaid, you just didn't have that back end where people were rolling off.
And it sounds like the Big Beautiful Bill is addressing some of those issues with the role of people on Medicaid or the number of people on Medicaid. But question for you, since you have so much experience in it, what design principles do you believe are most critical with reforming Medicaid, just to ensure that there's still access to Medicaid and it can be sustained?
Yeah, I think if you think about it, there's always been this tension, particularly felt strongly at the state level, where most states have a constitutional requirement they have to have a balanced budget. So there was always in this tension of what all things can we do or should we do, and what are we able to do. I would tell you in my years in public service, I was 20 years in public service, there wasn't a year where we didn't have to make some kind of reductions. I will admit to you, it was not always easy, but what it did do is force us to think differently. We still had the member, at the center of our thinking. How can we serve them better? But we also had to think about how we could serve them differently. That forced us or prompted us to break down some silos that had built up over time. It had us confront some, I'd say, political third rails that, people didn't want to touch because, of strong lobbying or strong resistance to making changes. But what I have found is over those years, working with those different stakeholder groups, helping have them at the table as we're talking about how we can transition things. We ended up doing a lot of creative things that ultimately, which people don't always appreciate, but it lowered our growth rate significantly to one of the lowest growth rates in the country, while also improving quality. So it can be done. It's not a quick fix. It's something that you have to constantly work at and constantly iterate at. And you have to, from a state perspective, you have to be willing to actually have stakeholders around the table as you're talking about those changes, if you want to be successful. I always said is like Medicaid folks that are working within the agency, they know a lot, but they don't know everything. And so they need that added data, viewpoint or data point from providers and other stakeholders in the community to actually help inform new programs and new approaches. I always use this example to talk about just the great variation in Tennessee alone. Is Northeast Tennessee and Johnson City is actually closer to Canada than it is Memphis. The challenges within Johnson City are very different than challenges in Memphis, and the way that we approach solving those need to take that into consideration. And you can't do that just sitting in Nashville with your office door closed. You have to actually go into those communities, meet with providers in those communities, meet with members in the communities, in order to come up with solutions that can move the program forward, again, under the constraints of limited resources.
And you obviously did a very good job while you were there, because I read that Medicaid recipients had a 95% approval rating for TennCare, which is tremendous. So great job there. And I agree with getting a lot of different perspectives and getting help from the communities to serve this population. So I want to roll into now the one big, beautiful bill and some of the requirements that are coming out and get your thoughts on this. So the work requirements, and we discussed a little bit of where Medicaid has come from, how it changed with COVID and with the ACA programs. But there's new work requirements that are being put into place. And specifically, able-bodied adults aged 19 to 64 must work, volunteer, or participate in job training for at least 80 hours per month to maintain eligibility. I wanted to get your thoughts around that first, based on the history. And then I'm going to ask you about, how do you see the states implementing this potentially? Like, you can get like a W-2 on work or see how much money they've made, but how do you track volunteer hours or job training? So,
Yeah, I have not had to implement, in Tennessee, we had not implemented work requirements or community engagement. However, I have worked with a state that has, and worked with them from concept all the way through implementation. And it is not easy. And I will say, I think folks are still learning on how best to approach this. Let's back up for a second and remember, why has this discussion been so important and in the center of debate pretty much since the ACA passed? And at its core, folks who advocated for it and pushed forward with it is, if you look at the traditional coverage groups in Medicaid that I talked about earlier, they weren't talking, hey, let's do community engagement work requirements for that population. But we added a new group, approximately 20 million individuals, that 19 to 64 expansion population. And the belief was, we're extending coverage in a pretty significant way. and it's a different population. Should we think differently about what our expectations are? And the belief was that asking individuals to have some level of community engagement was not too much to ask. And I heard that I've heard that from federal officials just this week. They believe that they've structured it in a way that it is attainable and accessible. A lot of data out there that shows a very significant number of Medicaid beneficiaries in that category do in fact work or go to school. The question is to your point, are there ways to stand this up that can address some of the challenges that come with the requirement? And I will say, Arkansas was one of the first states that really stood it up and implemented. They had a lot of struggles and challenges, well documented. Other states, have taken different approaches that try to do it as well. But what you see in the bill that just passed and was signed into law is that this is structured differently than all of those. There's different categories of exemptions. There is an expectation of leveraging systems to minimize reporting challenges and difficulties. We'll see how that works. I remember having this conversation with folks in DC as they were talking about, how you stand one of these things up. It can be administratively complex or it can be easy, and there's a continuum there. And, I think they did try to lean more toward making it less cumbersome, but, states will have to stand this up in fairly short order. I think when this was passed, and I had a lot of conversations during the discussions and debates, is people tend to forget that the state process is not necessarily a quick one. They're going to first understand, get the rules from CMS that haven't been issued yet, but when those rules come out, that will help them understand a little bit more about how they need to approach operationalizing this. In many cases, they'll have to get additional appropriation in order to maybe get new systems, build out new personnel, given that there's some other changes on frequency of eligibility checks. And then they're going to have to, stand those things up. And that is not a quick process. It probably would be if that was the only thing you're doing. But at the same time, this is the old adage is, you got the plane in the air and you're trying to keep the plane in the air while you're making all of these changes. So, I think states will do a great job of finding ways to make this work as best they possibly can. I think they'll continue to iterate, learn more, and find new ways to do that. But in the meantime, it's gonna be a bit of a lift for states to get this stood up in the amount of time we have available.
Okay, so you mentioned access to systems to help. Can you expand on that a little bit? And will it help the hospitals, or is this just the state setting something up, or do the hospitals access it?
Yeah, so the intent is, to the extent you are able to leverage existing data sources.
Like, give an example.
In some cases, when it's schools, can you get a feed from the universities or other, even technical schools that may qualify that will let you know that individuals are in fact enrolled full-time? You can wage file information, which will help you understand what level of income they're bringing in. Volunteer is a little bit more challenging, but I would say work and school, I think we've seen folks think about different sources for that information that can help validate this. Now, again, when I talked about how they approached it here in OBBB, they ended up saying you're not having to check the individual every month for that, but it's once every 6 months to see whether or not they qualify. That will reduce some of the administrative lift or burden, both on the member but also on the state. However, some of those data sources, you have to think about, again, this is where the rules coming out of the federal government are going to be helpful. But let's say an individual is a student and they're in the middle of summer session and they're not in school. How do you handle that? Maybe they were a full-time student and they're enrolled for the upcoming fall session, but helping states figure out some of those nuance challenges, but that gives you a little sense of why they're saying it's like encouraging any way that you can to help minimize that lift. And again, I think the other thing that we can't forget is some of the exemption groups and categories as well that were in the bill that is different. Like if you're a caregiver, that's an exemption, and states are going to figure out processes and say, how do we define caregiver? How do we validate caregiver as well? So a lot to work through. I think states will get a lot of that information when CMS issues some of the rules and guidance, but we'll see.
Any idea on when it will be issued?
That is a question I get from states pretty much on a daily, weekly basis. The first rules that will come out are going to be around the rural hospital funding, which I'm sure we'll talk about at some point. But soon thereafter, just given the schedule of events and how things will have to play out, work requirements will be shortly thereafter.
Yeah, the work requirements, I tried to get some timelines here. They're supposed to be in effect and the eligibility verification done semi-annually by December 31st, 2026. So that gives about a year and a half. So hopefully we can get it, the states can get it done and educate the hospitals, and hopefully it'll be easier if they have access to different systems, like you said.
And I should say is I think, hospitals, health plans, the lessons learned from COVID where, a variety of different entities leaned in to try to help, like when we're going through the unwinding of the public health emergency in COVID, where a lot of different entities look to help, get information on folks who are coming up for an eligibility check and helping to reach out to encourage them to engage, asking if they need help. I think there's been some lessons learned that, again, will make this different than what we've seen historically. There's a lot of people thinking about how they can help with this lift and make things easier for the member.
Great. So because you touched on it, we'll jump to that, the Rural Provider Relief Fund, because that is coming up fast and furious, and states have to apply for that money is my understanding, and hospitals will have to talk to the state to make sure that they get some of the funds. So do you want to talk a little bit about that?
Yeah. Dr. Oz was here in Nashville earlier this week and talking on that particular point, saying, he's encouraged with some of the creativity and innovation that can come from this $50 billion fund that will go to states and go to rural health. The challenges I see, and this, you're exactly right. Hospitals, this is something hospitals need to be leaning in on right now. This isn't something you need to put off, because the way the law was structured is the applications to access this funding are due by the end of the year. From what we have heard from the administration, from CMS, is that they will be putting out some options that states can consider of some proven strategies that have helped in rural areas, in order to help states along in their thinking. But states can also request different approaches. But I think it's going to be helpful to states that they have some things that they can look at, somewhat of a menu of items that they can look at and choose from. But the timing is really short. CMS is going to put out guidance, put out the applications, and states are going to have to pull together everyone in short order in order to get feedback on what's the best strategy for their particular state, and then get the funding and implement it. But right now I'm less concerned about the implementation time frame. I'm more concerned about the short turnaround on putting these plans together and get these applications in. And you have to remember, legislature is out of session. So I'm sure the legislature in many states are going to want to have some say or perspective on this as well. And the only way that can happen, like globally within the entire legislature, is if there are special sessions called related to this. So more to come there, but this is a time for hospitals. We're not talking wait for all the guidance to come out, but already start engaging with your associations, engaging with the state agencies, talking about different ideas and thoughts that you have on what could be helpful in strengthening and lifting up our rural delivery system.
A couple questions around that, because I agree, hospitals need to jump on this right now. Do you recommend they start talking to their state reps, Medicaid reps? Do they keep watch on CMS? Like, what do you recommend that hospitals, specific steps that they need to do right now?
So in just looking back in history and how I engage with hospitals, I know whenever big things came up in the past, hospital associations would form work groups themselves. What I would encourage is that you don't spend so much time working, just on that side of the equation, working within the association and waiting before you engage the state. I think just given the timetable here, I think you're going to have to accelerate your engagement with the state, even maybe before you've kind of worked out what all you think should be in that plan. Start having conversations, because it's going to need to be kind of a live evolution, just given, I know it feels like we have time given here we are in toward the end of July, but I will tell you, just knowing how states have worked over the years, or government in general, when you're talking Thanksgiving and Christmas, you're taking time out of that schedule as well. So this is where I'd engage now, even before you have a fully ready baked plan, to talk about ideas, concepts, things that y'all think are important with your state agency now. And as that thing firms up, hopefully, that will mesh well with the timetable and getting that application in to CMS.
Love that. So I want to talk about two more things around this bill and then get into some operational financial impact things. So the provider tax restriction. So I want you to explain what that is first, because I didn't have any idea when I talked to you before about it. So I had to do some research on that and the reductions there and what that means. And then we'll get into some of the dish cuts. So provider tax restrictions, what are the
provider tax has been a key financing tool for states for many, many years. I'd say last I checked, 49 states leverage provider taxes in some form or fashion. There's different provider taxes. And, I usually refer to them as Medicaid taxes, because it's not always just provider, because there's MCO taxes as well, managed care organization taxes as well. There are different requirements or restrictions around taxes that happen. They can't be more than 6%. They have to be uniform, broad-based, and there can't be a hold harmless provision. These are requirements the federal government put in place to be able to say, this is kind of your safe harbor. If you're going to implement a tax in this area, it has to meet these requirements. And that has been the case for some time now. States use the funding that's generated from these taxes to help support the broader program. So when you have these taxes, it brings in additional federal funding into the state that are then invested in the program. So when you're talking about changes to how these taxes are done, that could put pressure on states' financing. It's definitely an area that's got a lot of folks' attention. And the way the law made changes to it was basically saying, if you are in an expansion state, and that's basically 40 states in the District of Columbia, the current cap of 6% will decline or phase down to 3.5% by the year 2032. So what does that do? Well, each time that phases down, those taxes currently support some spending in Medicaid in that particular state. So as you think about that, and I should say this is, the level of tax varies. So you may have a hospital tax at 5%. You may have a managed care tax at 6%. They just vary. Nursing home tax, ambulance tax, there's a variety of them. So as this begins to phase down, in some cases, it's very clear what those funds support. In our case, when we had a hospital tax, it was very clear we had to itemize the different things within the program those funds support. There's going to be a discussion, obviously, that has to take place. This is another area, not from a time perspective, not like, again, I think rural has to be prioritized, but maybe concurrently or shortly thereafter, you are having a conversation with the state about how they are thinking about these phase downs and what things will continue to be supported and what things will not be supported as the taxes decrease over time to that 3.5% ceiling. I do think some states will look at phasing down how they're spending Medicaid funding to fit within that requirement. And other states, I think they'll look for ways that they can mitigate or soften that phase down by using pure general fund dollars. Some states are going to have more flexibility than others, just giving whatever their current revenue situation is. But that's one of those things you need to you need to have a seat table. You need to have a discussion. That one, how states will transition on these phase downs will take place, in legislative sessions as they're building their budgets in the years ahead. So, you'll have time to engage in the public process. But again, I wouldn't wait on that one either. Would want to understand, what's obviously most important. If there's certain things that are being funded, and like say the hospital tax are important for the hospitals, states need to hear that. My bit of advice there is, and this is just from experience over the years, to come in and tell me like, well, everything's important, you can't change anything, that makes it very hard. Need to talk about the things, prioritizing what's most important, ways to mitigate some of that change. Are there different policy decisions the state can make that make other things easier for that particular provider group? It needs to be an open dialogue, but this change or phase down in financing definitely is going to put some pressure on the system.
Having said that, so it's going from 6% down to 3.5% over a period of years. I think you mentioned 2032. What does that mean for hospitals? Is that a good thing or a bad thing? They're going to be taxed less, but it'll be less money going to Medicaid and less federal matching dollars. So what does that all mean for hospitals?
So again, it varies state to state, but typically, let's say if there's a hospital tax in place, typically the funding generated by those hospital taxes help support hospitals. So yes, you'll pay less in tax, but some of those things that the funding supports could have an impact on those hospitals. I will say in some states, I've heard this from others, that they may tax hospitals and use that money for a variety of different things within Medicaid. So it may not be a one-to-one impact on the hospital system, but that's going to put funding pressure on the program. And that will be either from the perspective of they may have to make base changes, like current funding I'm going to have to pull back, or it may just curtail, future investments within Medicaid because that funding availability, they're feeling that pressure that the tax that they once were getting is actually going to start stepping down. So how it impacts a hospital is going to vary state to state. That's why I'm saying you cannot go wrong by engaging the state early. How's the Medicaid agency thinking about it? What do they think the impact's going to be? And come into an understanding, at least your starting point. Like, this is what we believe the taxes have been supporting up to this point. This is what the phase down will result in. And then having a discussion of what, if anything, can be done about that delta.
Okay. And last question on it, because I'm just curious about it. When the state has that body of funds, can they disperse it how they want? So, for example, does more funding from this tax potentially go to rural hospitals versus an inner city hospital versus a safety net hospital?
Great question. Typically, when the taxes go in place, there is discussions back and forth with the hospitals and the state and trying to understand what impact will it support. So yes, it can, they can say, we want more funding, increasing the rates that we pay to rural hospitals, for example, or some additional support for safety net facilities. Absolutely. A lot of those discussions happen when the taxes first were developed. I know from my experience, that it was an annual discussion with the hospitals about how those taxes were being used. I don't want to assume, and I know this just from talking to other states, that not all states is it as abundantly clear, because in some states, maybe a hospital tax and a portion of that or all is being used for generally funding the program. And so what is the state thinking about as it phases down what program funding would be impacted, going to whether it's hospitals or other aspects of the program. So that's where I say that conversation early is going to be helpful. Understand that states probably haven't fully fleshed out how that phase down will work exactly and really modeled it. But I do think the earlier you're involved in the discussions, then you understand the facts and understand what the potential impact is. And, obviously, again, this is going to play out through the legislative process. And, if there are ways to impact that as part of the budget process, then I'm sure that's going to be another opportunity for hospitals to engage.
So another significant source of funding, especially for safety net hospitals, is the DSH payment. So that is being brought up again. It was brought up with the ACA programs, thinking that patients that were indigent or getting charity care would move to ACA. But now they're talking about more cuts to the disproportionate share, and they're supposed to take effect in 2025. potentially reducing federal dish allotments by up to 50% in some states, which is significant. So talk a little bit about dish and what you're seeing. I know there's been a ton of delays through different legislative bills brought up, but talk a little bit about dish for me.
So the idea or the thought process there was, if we're going to cover more individuals, there's going to be less uncompensated care. It's not a hard thing to understand or appreciate. We had that experience in Tennessee when we had expanded coverage pretty dramatically in the 90s. Same thought process. What we learned then, what Massachusetts learned some 10 years later, same concept, is that it didn't eliminate uncompensated care. It had an impact, but it didn't eliminate it. And so as part of the ACA, they did have a requirement that that disproportionate share hospital payments would reduce over time. That has not happened. It has continued to be delayed. It reminds me, it's kind of like the doc fix of the day. It just keeps getting pushed further and further out. It's supposed to, I think the first phase or round of those cuts are slated for later this year. I think this is one of those things is like there's a lot of different things going on for hospitals, and that's not lost on me. It's not lost on other folks in and around the Medicaid space, or, even more broadly. But you're looking up at this thing that Congress is going to take up and have a discussion on. So, right now it's scheduled to go into effect. Will they push it out? There's a strong possibility, particularly given that in light of the big, beautiful bill that just passed, that I think that's going to be a lens that they're going to look at that and say, should we be implementing this? Should we let the first phase of that go into place? So that hasn't been decided yet. Clearly will have to be picked up here in short order. We'll get more clarity about that. But I think if you factor some of the changes that just came out of the big, beautiful bill, and then you marry that with the DISH changes or the Medicare rate changes that just came out recently, there are a lot of different things that are going on that they're creating a significant amount of disruption and to some degree uncertainty on how folks are going to have to navigate it. So the way we always handle that as a Medicaid program is like, deal with the fire on your doorstep before you worry about the fire coming down the street. Right now, some things that are happening right now because of the law that just passed. Focus on that. Clearly, you'll be having discussions with congressional members. The associations will be having discussions with congressional members, about, the DISH cuts and how that, on top of everything else, how will that impact hospitals? I think having discussions, do not take for granted, that people think about kind of the layering effect or the global effect of all these different changes on hospitals and how that impacts your systems and those communities. I think it's important to get in front of them. Don't take it for granted that they're going to kick it out or push it out further. But at this point, I also wouldn't be making the assumption it is absolutely going to happen either. Okay. That they're going to go into effect.
I know a lot of safety net hospitals rely on those DISH payments. So that's some good points there. So I want to jump into, what do you recommend hospitals do today to avoid a major impact on revenue, ACA plans as an example? So what can a hospital do today, everything that we've just discussed, to try and preserve some revenue?
We bring up the ACA plans, the marketplace plans, and I think that we also have to recognize the enhanced premium tax credits is another big topic that's on the horizon. So I think the popular opinion is that they're going to let them expire, in which case then you're going to have even more increased uncompensated care, more increased uninsured. My thinking is that it's probably going to be some hybrid approach. It isn't necessarily that they're all going to go away. There's going to be more creative or thoughtful consideration on how best to handle that and exactly what to cover there. But, just thinking about the system broadly and all these changes that are going on, few things stand out. Regional collaboration, working with local governments or health departments to fund key services and help support those. Clearly, again, we talked about some of the, briefly mentioned the changes in the Medicare fee schedule where, things that historically been limited to happening within the inpatient setting are now opened up. So there's clearly going to be, more emphasis on outpatient care. I think that what we talked about, engaging in policy, working at state level, coming up with state level solutions around financing flexibility, looking at and exploring options around value-based initiatives. Are there different payment structures that are going to help hospitals navigate these changes more effectively. I think states are going to be very receptive to that. I do think that, again, don't take for granted like the Medicaid agency understands some of those other changes that are going on. Clearly that all isn't their responsibility, but you need to help them and other policymakers and lawmakers understand and appreciate that it isn't just, for example, the provider tax going away and a state changes that may impact hospitals in response to that. It is that and this broader array of changes that are going in place so that they can fully understand and appreciate that impact. I do think that every year that I was in public service, I had to make reductions. It's not easy, but I will say it does force innovation and creativity. And so I do think that there are some opportunities after you get past kind of the challenges of like, I'm thinking about it in the world in the context of how we've done things historically and instead shift to we're going to have to do things differently. Then I think that you're going to, be able to navigate or mitigate some of these revenue hits in a way that helps the system adapt and change. And how you do that, how you engage in that is going to be important, because I do think if hospitals believe states can make up, some of those changes on pure general fund, that's just, looking at math. I just don't see, and maybe in some markets they can, do so significantly, but in other markets, I just think it's going to be challenging. So you have to have a discussion about how do we think about this differently? Are there other changes the state can do that actually help make operations at the hospitals and the systems easier and less cumbersome and less costly? Those types of conversations, I think, should be taking place too. So not just thinking about how do you replace some of that revenue loss with other revenue sources from the state, but how do you also make doing business easier for those hospitals and have those conversations as well?
So I'm going to ask you one follow-up question on that and then one closing question, and we'll be done. So value-based Medicaid models, do you see more of those coming out then with one big beautiful bill coming out and all the changes and pushing for, reducing waste in hospitals?
Yeah. So, I don't see that necessarily the new law, does anything particular to advance value-based care, but it doesn't prohibit it either. So I still think states have plenty of tools to drive innovation in that area. I think they're going to continue to be focused on it, figuring out ways to align incentives, improve outcomes, manage costs more effectively. What I do think, you have to understand and appreciate, you have so much air in the room or so much bandwidth as a Medicaid program to implement changes. And right now, let's say if a state had a variety of value-based models that they were wanting to roll out, and they were in the process of doing so, you may have to slow or postpone some of the implementation of those things because you have to respond to the requirements of the new law. And, I don't think that's a long-term pause, but I do think short-term, it's going to take some of that bandwidth away from pushing out those new models to standing up some of the requirements of the new law. But then I think the overall pressure on the system from a revenue perspective, in a cost control perspective, I do think states are going to continue to lean on coming up with new innovative ways to pay providers that I think providers should be thinking about and hospitals should be thinking about as a way to, again, adapt to some of the changes that are being implemented. And states, I will say it's hard. I've been involved with value-based models since about 2008. And so it's not easy. A lot of states have experimented with different models. I think this might actually have more folks come to the table to have discussions about new models, just given some of the changes of the broader system as a result of the law's passage.
And you've already kind of touched on this a lot. This is my last question for you, and I thank you so much for all your valuable information. But how might this reform better position Medicaid to support needs going forward? And you've already touched a lot on it, but just in a few quick sentences.
Yeah, I think it can if we take the long-term view. Obviously, the healthcare landscape's changing. We have more complex patients, aging population. rising significant behavioral health care needs. This is a moment, I think, where states and systems can build smarter, more integrated, outcome-oriented Medicaid programs. The key here is to stay focused on the mission, use every available lever, but also, again, be solution-oriented. Let's think about, there's this appreciation that there are limited resources. So how can we move this forward, strengthen the system more broadly, but also make sure that it's sustainable long-term?
Well, thank you very much. And I'm going to end with 3 things that I think hospitals should do right now from what we talked about, but they need to stay on top of the regulations as they come out and they are issued by CMS to the states. Get involved with their state hospital program. I like your idea of maybe the hospitals can come up with ways to save money for the Medicaid program potentially. They see how care may be wasteful. And then also stay in touch with your hospital association. So Darin, thank you so much for talking to me today and great information on the OBBB and Medicaid changes. Thank you so much.
Thank you. Appreciate it.